Okay, so I was asked to discuss some of the important considerations when a patient is newly diagnosed with a potentially a kidney cancer. Um, so just an outline here for us to discuss. I'm going to start discussing about how we identify kidney cancer, really what are the proper scans that we use for the diagnosis, and also the workup or staging. Discuss an emerging scan that could be on the horizon. Common topic is why don't you want to stick a needle in and biopsy? When do we do that and why? Also discuss the role of surgery, which can help diagnose and also treat. And something that people have been asking very often recently about, are there any blood-based tests that could be useful in the diagnosis? What's on the horizon as well? So kidney tumors come in a wide variety of forms. I think we've heard that there are multiple different types. I like to call them flavors of kidney cancer. While there are multiple flavors of soda, they all are in the soda family, but they all are quite different, whether it's Sprite, Pepsi, or Dr. Pepper. Some of these tumors really never needed to be found. We know that in the 1960s and 70s on autopsy studies, people would be incidentally found with a renal tumor when they died of, let's say, hang gliding accident. And that would be found in maybe 2 to 3% of patients. Today, we see that much less often because we're probably identifying that reservoir of patients who may never have died from, but died with, and found later with an incidental renal mass. Other kidney cancers can spread very rapidly, lead to death within a few years. Fortunately, those are in the minority. How patients have been diagnosed today in 2025 has really changed dramatically. But there's a wide variety of symptoms, such as someone who's symptomatic coming to the ER with maybe flank pain and abdominal mass and blood in the urine. But now 70% of cases are found what we would say is accidentally in most developed countries. We'll dive into that a little bit more in detail. Now, this is one of my favorite slides. These are two tumors I removed the same exact day. One which was really a typical presentation, someone who was found with nearly a 20 centimeter tumor. This was common in someone in the 1950s, 60s, 70s, 80s, 90s. We see it less often today. This would be someone who really presents with symptoms from this giant mass, which can cause some local pressure irritation. But then this other little thing on the right, this was something which clearly you're not going to, really feel. I like to equate this, that Hans Christian Andersen book about, the princess and the pea, putting the pea under the mattress. The kidney is very well protected, and you can put a little lump on the kidney, you're not going to really feel that. And when someone comes to us with low back pain, and they're found with a cyst or a small mass, we can tell them, 99% likely it is not the cause of those symptoms. If we're going to remove the mass, I will tell you 99% of the time that symptom does not get better when a patient has a small tumor, because these are largely asymptomatic. And back pain is very common. I have back pain right now on my left flank. I've ultrasounded my own kidney 3 times, but it's usually not due to the kidney or specifically small kidney tumors. Now, again, prior to the 1980s, we called this the triad, which was flank pain, feeling an abdominal mass, and having blood in your urine. Rarely microscopic. This would be gross blood where a patient would see it. And fortunately, we don't see this as often today, maybe only 10% of the patients that we see. And this incidence of presenting with this triad is pretty similar today than it was in the 1950s, 60s, 70s. Why? Because those types of tumors generally are ones that really are not often found accidentally. Those are ones that are really rapidly kind of forming and developing. Now, the subtle signs of symptoms, which we occasionally see, more common with, advanced cases, things like fever, cough, or abnormalities in the blood. Calcium, high blood count, calcium being high, liver tests that are high, other things or peripheral edema in the lower extremities, having swelling. That's why kidney cancer used to be called the internist tumor, because we needed a very astute internist when a patient would say, "Hey, I'm having maybe fatigue, or I'm having swelling in my legs," to really kind of figure this out. Now, this is very different today because of the advent or the widespread availability of scans such as CT or MRI. And then this is just a graphic representation over, in the 90s to 2000s, how there's an explosion in the number of scans among patients in the Medicare population. We call the CT scan in the ER the tube of truth, because you're going to see what you're going to see, what's inside. My hands are very sensitive, but I can't feel a small renal mass. And we know patients are going for scans more frequently than ever before. We hear crazy stories. I have one patient got bit by a spider in her mouth, had a panic attack, ended up getting a chest CT to rule out a pulmonary embolism, caught the very top of the kidney, and then went for, abdominal scan. We see this all the time. But in general, in the Medicare community, patients 65 or older, within 5 years, about half of patients are going to get a scan of their chest or abdomen. And a lot of times we find things, on a lumbar MRI or an ultrasound of the right upper quadrant for gallbladder symptoms, such as, pain with eating. We find lumps or bumps. Now, by looking for things, we often find the small tumor in the kidney, which was unlikely to cause symptoms. And we have an epidemic of what we call small renal masses. These are usually tumors that are less than 4 centimeters, and the number of cases has exploded. We have about 4 times more kidney tumors today than ever before, and this was attributed to the increased utilization of cross-sectional imaging. We do have other factors at play, likely raising the incidence, such as the obesity epidemic, the aging population, and potentially emerging data that some environmental things like forever chemicals, potentially could contribute to kidney cancer incidence. But again, we see more of these small lumps or bumps than ever before. And we don't really know what all these are destined to do. So when a patient comes in, generally with a scan, they usually come to a urologist office, and the scan often is not meant to diagnose the renal mass. Someone had a lumbar MRI, not sufficient. Someone who had a scan of their abdomen with oral contrast when they were vomiting, usually not sufficient. It's important to obtain proper imaging to ensure the accurate diagnosis, also staging, and the ability for us to treat potential kidney cancers. Now, there are different approaches, but the Society of Abdominal Radiology, which is one of the organizations that focuses on imaging the abdomen, which is where the kidney lives, considers a single scan, such as a single phase CT scan, or maybe a dual scan without or with contrast, really insufficient to diagnose kidney cancer. While an MRI or a CT are both acceptable, the Society of Abdominal Radiology suggests that we get multiple contrast phases. We call this a renal protocol to really confirm the diagnosis of a renal mass that's suspicious for kidney cancer. The issue is if you fail to perform a proper workup, it could lead to inappropriate treatment or unnecessary treatment. Now, there are common pitfalls that I see very often, okay? One common pitfall, if you don't do a proper workup, there are some things called hemorrhagic cysts, proteinaceous cysts. These can be seen on IV contrast phase alone. They look bright. Most kidney cancers on IV contrast phase look bright, but these are benign and they are misidentified as suspicious for kidney cancer because unlike kidney cancers, which usually are darker, and then with the contrast, they become bright as that heavy, dense contrast flows through the tumor, a hemorrhagic cyst has old blood, or a proteinaceous cyst has like a milkshake material. And if you did a scan before contrast and then gave contrast, it wouldn't become any brighter because those do not have any arteries or veins through the lesion. So again, a common pitfall. You need to have a scan without and then with contrast. Another common pitfall we see are cystic masses. Cystic masses are lesions that are not a simple bag of fluid, but they're not a solid mass of tumor cells. And we have a scoring system. One of my former professors at NYU, Dr. Morton Bosniak, he was tired of urologists removing things unnecessarily. So he came up with a scoring system, which has been revised multiple times. And we'd like to just kind of classify tumors with this system. And we know some lesions that have low complexity with little dividers or septations, or ones with lots of simple dividers. These have a very low risk of being malignant. We do not need to run and remove all small lesions. Now, multiple phase scans again can suggest something might be benign or might be a fat poor AML. So this type of scan could be very useful to get a better understanding of whether something is an oncocytoma or a fat poor AML. Now, staging workup of kidney cancer is critical. Once a suspicious renal mass is found, we need to understand the extent of the disease, the stage. It's very critical to give information about how the tumor extends, or is it actually moved to another part of the body? Again, local staging, the invasiveness. Here's just an example of a tumor, which clearly on the red arrow, it is a large round mass, and there's some haziness around into the fat. And then that yellow arrow is a rib lesion that moved and spread. We call that a distant metastasis. Now, it's important for us to figure this out. Now, again, when we see a scan, just an example here, this is a 3 to 4 centimeter tumor. We have a way to clinically stage a tumor. And this is a tumor which is kind of extending potentially out into the fat. This is looking at the tumor from the side, or maybe into the sinus. So it's unclear for us whether this can be a clinical stage T1A tumor, which is not invasive, or a clinical T3A, because microscopically, it may be invading into the fat outside that black area, or on the right side of the tumor, or invading in the inner sinus fat, which is called, sinus invasion. But if you look on the right, this would be a 10 centimeter tumor we removed last month, and there's invasion clearly into the renal vein, and in the yellow up into the IVC, up into the edge of the heart. And clearly, there's no question there that is a clinical stage T3C, because we're convinced there's invasiveness. We know that is clearly a kidney cancer. Now, imaging for staging varies between organizations. There are multiple organizations, and they have their own guidelines. AUA, American Urologic Association, the NCCN, the National Comprehensive Cancer Network, EUA, the Europeans, or the Canadians. They all have their own recommendations that slightly differ. However, all support if a patient gets appropriate renal imaging and has suspicion for kidney cancer, a higher risk tumor should have a chest CT, because lung metastasis is the most common organ of involvement outside the kidney. We do know for tumors that are small, less than 3 centimeters, or cystic lesions, there is a very low rate of metastasis. Traditionally, the staging workup of a small renal mass is just a chest X-ray, and the AUA, EUA, CUA all suggest that. There is some new guidelines for the NCCN, which many of us don't agree with, that a little tiny nodule on the kidney, probably it's not worth the chest CT radiation exposure. But again, all of these organizations suspect a large tumor would have enough risk to justify a chest CT. Now, a bone scan or a brain MRI, those are largely guided by symptoms. If someone had severe headaches and seizures, we would want to get a brain MRI. Or a bone scan if someone has pain or a fracture. You see here, you're not usually going to see a little tiny lesion in the mediastinum above there. That's another scan we'll talk to in a second, called a nuclear medicine scan called the PET scan. So we have guidelines for staging. We don't have to always get every single known type of staging scan in the books. A lot of it's guided by risk and also guided by symptoms. Now, the PET scan, as I showed you before, a PET scan is a metabolic imaging study, and that is used in a wide variety of cancers. Traditionally, a PET scan is done by injecting a small tracer, which is a trace amount of radiation, and then we do a scan. And that scan detects if the tumor was to take up a small or trace amounts of that agent. It's not routinely recommended in kidney cancers, even though it's used in many other cancers like seminoma of the testes or lung cancer. It is not useful for primary tumors in the kidney. And why is that? This radioactive sugar, FDG, it gets taken up by the kidney normal parenchyma and it's excreted into the urine. So the kidney is kind of a blind spot for that imaging modality. And it doesn't really add much value to confirm or exclude distant sites in general. If someone has a 3 centimeter lung metastasis or suspicion, it's not really going to change our approach. And none of our guideline agencies recommend FDG PET scans, but the NCCN this year said if considered clinically necessary, and there are some rare subtypes of kidney cancer which your doctor may feel it could be useful. There are new tracers emerging, which include CA9-based PET scan imaging. CA9-based imaging is a common target found on clear cell kidney cancer, and it's also found in what we call hypoxic tumors, which are starving of oxygen, and occasionally some of the really bad papillaries or sarcomatoid transformed kidney cancer can express this. We were all very hopeful that the FDA would approve it last week, but there was some manufacturing questions, and this is going to probably be resubmitted in the next 6 months. We're hopeful. This is something that is emerging. This is not yet FDA approved, but as you see here with that arrow, you might see a tiny little lesion on the kidney. You have a PET scan with this agent, which is girentuximab, an antibody, which detects the CA9 protein, and you see that fused PET CT. We have done about 100 of these studies at UCLA. We have multiple trials that are open, and we're very encouraged. If something like this, we would know there's about a 94% chance of clear cell kidney cancer, 99% chance of a kidney cancer in general. Now, again, this is another one showing another lesion that was not PET avid. It is not lighting up that looks clearly dark. Something like that would have a higher chance of being a papillary tumor, chromophobe tumor, and probably 40% chance of it actually being a benign renal tumor like an oncocytoma or maybe a fat poor AML. So in my practice, if this does become available, I'm going to be using this up front and then probably doing a biopsy second for the cold lesions that have suspicion of not being a clear cell kidney cancer. Now, what about a biopsy? Patients always ask, is a biopsy needed? Well, most renal masses are cancer. 80% of lesions 1 to 4 centimeter are kidney cancer. And some advocate for a biopsy. Others say it's unnecessary. A biopsy has some minor risks and doesn't change prognosis, but it can be informative. However, sometimes it could be non-diagnostic. And some patients don't need a biopsy to decide management. So a biopsy is using an ultrasound or a CT, looking at the tumor and directly sticking the needle in to confirm probably the diagnosis. If it's cancer, on the biopsy, 99% chance it'll be a biopsy when removed. It can potentially guide treatment sometimes to give knowledge about the tumor. Now, when will a biopsy not be helpful? Well, an older, frail patient, maybe someone who's in a wheelchair who had prior heart attack. I don't care what that 2 centimeter mass is. I'm probably going to monitor it with active surveillance. Younger, healthy patients, if I say, listen, I'm going to have to follow this for the next 40 years of your life, it may be benign, but I'm not sure. Many of those younger patients would desire treatment regardless. They do not want uncertainty. And then a tumor that is maybe causing symptoms, we don't really necessarily need to know what it is before if it's not going to change management, because after it'll be looked at. So in my practice, if I know a tumor is not going to go for surgery, I will biopsy something that is metastatic at the easiest site, maybe the kidney, maybe a metastasis, because we want to know that prior to starting systemic therapy. An unusual tumor, if there's characteristics that the tumor looks funny, If a patient's very early age, and I think that maybe there's enrichment for other strange tumor types that are not classic renal cell carcinoma, I would biopsy. Someone with a history of metastatic cancer and multiple other maybe sites of metastasis from that, if I'm going to want to work up a kidney tumor, I may think about a biopsy. And then some patients are just uncertain. They're not sure what they want. And again, if I give them information, it might help them. So again, 90% of patients in the US have surgery without a diagnosis, and the larger a tumor gets, the more likely it's malignant. Invasive masses are clearly cancer. Biopsy may help confirm it is renal cell cancer, but it's probably not going to change the fact that it is a cancer, and if it's localized, probably going to come out. And symptomatic patients likely need treatment. So this is my algorithm. When I see you, I decide whether I need to obtain more information with a biopsy or further imaging. And again, if I don't get further imaging, I go right to management. If I do get further imaging or a biopsy, I can give you more detailed information. I always ask patients the following questions. Will knowledge of the tumor type change your treatment approach? And will you have any regret if a benign tumor is actually removed or treated, or if we know it's a cancer later on and we waited a while with observation and it did grow? Now, again, these types of tumors that are symptomatic, this patient with blood in the urine and flank pain, do I really need to know it's cancer? Probably not. They're symptomatic, coming to the ER. This invasive mass invading into the vena cava, young, healthy, no other metastatic disease, I'm probably going to want it removed. Now, in the final 2 or 3 slides, just quickly about blood tests. Blood tests are important. Clearly, a CBC or chemistry lab, we can find some subtle signs of the disease, a low blood count, high platelet count, or potentially high calcium. There are blood markers that are available on the horizon. For other cancers, these are used more routinely, like bladder or colorectal cancers. Tumor cells secrete these DNA particles from them. There are different assays. Some are specific to the tumor. Some are really agnostic, just looking at cancer in general. It is not something that is on any clinical guidelines. And the reason why is kidney cancers don't often shed cancer cells. You're looking for a needle in a haystack. However, if we do know if a patient has a large mass, some of them actually have shed cells that can be detected. After surgery, if you did have shed cells, it's rare, but those patients have a high rate of relapse. But currently, no clinical guideline supports the use of ctDNA for clinical decision making. There are other companies coming into this space. We're hopeful that maybe it would be useful in the future. Not very relevant right now, but there are ongoing studies evaluating for things like predicting recurrence, refining adjuvant therapy selection, or maybe when someone's on systemic therapy, deciding whether we're going to stop therapy. But an area of active investigation.